Hello, this is MSF ambulance. How can I help you? Hello, this is MSF ambulance. How can I help you? Uko hapo pale mgonjwa yuko? Okay, sawa sawa. Natuma na gari. Wakupigia na hii namba. Boni, hii ni namba yako wakupigie nayo. Sawa. There's a call from Mlango Kubwa kwa maji. You use Muratina Road as you're heading to Mudaiga. The caller is Boni. Boni has called pertaining a patient called Kanyutu. Kanyutu is an elderly patient, approximately 80 years, with history of having been lying by the roadside. He has been unresponsive ever since. He cannot recall the time, but saying overnight. He has been unresponsive. So I've instructed him to lay the patient by the side so that the patient cannot aspirate. So,
Boni. John. Boni.
Boni.
Thank you.
They will go assess the patient, stabilize the patient, then they'll get back to me. They will give me information on how they found the patient, the intervention they've done, and the intervention they've done. So my work from there with that information, I call the receiving facility. I look for a hospital where the patient is going to benefit, depending on the nature of illness of that patient. If it's Mama Lucy, Kenyatta, Mbagathi, or Mama Margaret. So I call the receiving facility. The purpose of calling the receiving facility is also to prepare them that this patient is on the way coming. So they are able to receive the patient smoothly. So we give the same information we relate to the facility. Yeah, and the team leaves the scene to the receiving facility and hand over the patient. We have documentation. They come with the documentation and then we feed them in our database. Yeah. Okay, my name is Teresia Macau. I work here at the call center. I'm a nurse by profession. So I'll give you a brief description of how we work or what pertains the call center or how we work here in call center. So when we come in the morning, we report at work at 7 a.m. We come, we take report from the night shift. So they give us details on what happened through the night shift, or if there is anything which we need to communicate with the supervisor, or some follow-ups which we are supposed to take. They give us all the report pertaining what has been done on the night shift. After taking the report, we allocate now. We have 3 ambulances, and they are manned by 2 people, the driver and the nurse or an EMT. So we allocate each ambulance with the team. After that, we now wait for calls. In dispatch here, we receive calls. Calls are coming from the community, from the police, from the other hospital, other health facilities, which they want their patient to be transferred to a bigger hospital like Kenyatta. So we receive all those calls here. They come through here. So we take the calls, we take the details. If it's from a caller or a community, we take details. Details will include the patient's name, nature of illness, and when we come to the nature of illness, we take a very detailed history. We also take location on where the patient is and the details of the caller, so that we can reach the caller. We can call the caller to get where the call is. So when we are checking the history, we also advise the caller on what they can do on the ground. They can do before an ambulance is being dispatched. For example, If it's a patient who is choking, we can advise them on what to do as they wait for an ambulance. Things like positioning a patient in a recovery position, or not moving a patient. If it's a trauma patient, that we advise them that we should not move this patient. So these are advices which we give the caller before an ambulance reaches at the scene. After that, these details which we picked from the caller, we give it to the ambulance which we want to dispatch. We give them the detailed history and what we have advised the caller to do. So the team will go plus the number and they will locate the patient where the patient is. They arrive at the scene, they do their intervention, and then they get back to us with now proper history of what is the nature of illness and what they've done to the patient. And they also, if the patient is to be referred, they also tell us that this patient will benefit by going to a certain health facility. For example, if it's Mama Lucy or if it's Kenyatta, they will advise us. There we call the receiving facility. We give them the details. The purpose of calling the receiving facility is that we prepare the receiving facility for a smooth receiving of this patient. Because at times we get hitches. If we don't call, the receiving facility is not aware of what the number of patients you are coming in with and the nature of illness. So it is very key to call the receiving facility and tell them about the patient who is on board. The team will come back with intervention or data of what they've done to the patient, and then we put them in our database. We have a database here called RedCap where we feed in all the information. Apart from that, we also respond to calamities. For example, floods, collapse buildings, and fires. We respond with other agencies and we work together in helping the victims or the victims when they are faced with such calamity. We respond to different emergencies. For example, road traffic accidents. We respond to medical emergencies. We respond to gynecological emergencies. All those calls, we respond to them. And we categorize this call. Once we get the information, we categorize this call to see if this patient fits in a criteria. We have a criteria on how we evaluate a patient and assess this patient needs an ambulance to respond.
Okay. My name is Pahola. I'm the emergency services supervisor for MSF Madare Emergency Services. The clinic is also known as Lavender House, MSF Lavender House Clinic. We are located along Juja Road, just next to Ola Energy Service Station. So MSF has been in Madare from the 90s, different projects, but the current project was started in 2008, initially as an SGBV, that is a sexual gender-based violence response center, and then from some of the emerging issues, it emphasized to what we have like right now, MSF Lavender House having the emergency services, and also still the sexual gender-based violence services, plus sexual reproductive health services. So in short, there are 3 clinics here, but I'm going to focus on the emergency services. So the project started in 2014, but it didn't just start in 2014. There were events that led to the opening of the project. So in 2013, that is after the elections of 2013, plus from history, that is 2007 elections, an assessment was done. And one of the findings is that there was a lot of unreported violence. The assessment was conducted in Mathare, basically East Slums, Mathare, Kayole, Dandora, Ruaraka, Babadogo area. And now the findings are partly informed the opening of the emergency service department. MSF being a medical organization and being known as an international medical organization, as much as we are providing services for the STBV, that is sexual gender-based violence, we would receive patients either who have had injuries from road traffic, sometimes emerging diseases like outbreaks, cholera. And the first place people see that this is an MSF medical facility, and they will bring in the patients. So that partly also helped in making the decision to open, because we realized there was a gap, and MSF responded to that gap in healthcare. So the objective of the emergency service is basically to offer access to secondary care. By this I mean that after pre-hospital, like the first aid, the linkage from the community to the hospital, because you realize the hospital that serves this area, East Slums, is Mama Lucy, and you can realize the distance between here and Mama Lucy. The services offered in the emergency department, or the emergency room here, if you'd call it, we usually treat casualties, that is of accident, either injuries from accident, from violence, from like road traffic accidents, what we call mass casualty, either falling from heights, because we also have a high-rise building. So all these type of injuries, we treat them. We also respond to medical emergencies, obstetric, that is like mother in labor, and also pediatric emergencies. We have the trauma room. We have the trauma room where we do the stabilization. It's more of pre-hospital. We do the stabilization. Sometimes we discharge from the trauma room, or at times we have to refer to either Mama Lucy, which is our primary referral facility, though at times we also refer to Kenyatta National Hospital, Mbagathi, level 6, I think it's level 5 hospital, and for maternal cases we refer to Pumwani, which is close to us. We also provide 24-hour ambulance services, which are free, and we operate a call center where we receive the calls and also dispatch according to the needs of the caller. We have what we call our catchment area. That is, we cover Mathare, part of East Slums, Eastleigh. So by Mathare, it's from Pangani all the way to Ruaraka, come back to Kariobangi roundabout, and then we go as far as Kiambu, which is on the other side of Eastleigh, including Eastleigh. At times we have to respond outside of our catchment area, and in this instance we usually get validation. So if the team gets a call outside of our catchment area, they call me, and then I usually escalate it and get the necessary validation for us to move. It's usually very fast. It's not as bureaucratic as it sounds. It's usually very fast because we just explain the situation and we respond. So in example of instances that we responded outside of our catchment area is like when we had the Embakasi fire incident, the Dusit attack, when we had a collapsed building in Tasia, and as recently as June when we had the protest in CBD. So usually we don't respond to in CBD, but because the needs were different at that time, we had to respond. So it's not like we are restricted, it's only within our catchment area, but there are exceptions, and we usually respond when there's need. Maybe also to mention, we usually work closely with the Nairobi County, that is the Department of Health, Nairobi County, and the EOC, the Emergency Operations Center. So whenever there's an issue, we collaborate. They can also call, and we usually partner with them. During the protest, we also partnered with Kenyatta National Hospital. We had our team stationed at Kenyatta, and we supported them with triage. So we don't work in isolation. We partner with the relevant organizations. Maybe also to mention, there've been instances of disease outbreak, most notably cholera. And we usually respond, whether it's in Mathare, we set up cholera treatment units, and we support treat. As late as, I think, 2023, 2022, I need to confirm, we set up a cholera treatment center at Mama Lucy Hospital. So we respond to disease outbreaks. Recently, we had the scare for Mpox. So as much as thankfully we didn't get any case, but we prepared, we did the training for the staff, for the screening, so that we were ready in case of any eventualities. So being a health facility, apart from the trauma center, we also do surveillance, and we prepare adequately in case of any eventuality. During COVID, we also supported, we had a response, we supported Mama Lucy, and we were involved with the management. Mostly they would come to us. So during COVID, we also had, we responded, and we supported most facilities, Kenyatta, Bagadi, and Mama Lucy, which is our primary referral facility.
Give us an average of the patients that the facility sees in a day.
So on average, when we're talking about all the services, we see around 90 per day, but they're divided between the different services. But for the emergency services, then I'll break it into two, because we have the call center, and they receive an average of around 30 calls per day. So these 30, around 24 we usually respond. So the other 6, either they would be advised on the phone, or they're outside the catchment area and they'll be directed to another facility, or they don't meet our criteria for dispatching of an ambulance. So of the 24, would have to do an intervention, and from these 24, maybe, from the 24, around 80% would need to do an intervention, so it's around 20. And from these 20, maybe another half of them would need to refer. But some of them we bring them, stabilize, and then we discharge. Or they are treated at the scene and then they're discharged.
So of the 24 that need intervention, is there a common ailment or challenge that usually with the 80% that you respond to?
Sorry?
Of the 80% that need intervention,
yeah,
majority are accident victims, or they are...
No, it will depend from day to day, because these are emergencies not planned. So there are days you'll find maybe there are medical cases. At times, maybe of the 24, maybe we had accident. Or it also depends with the season. Like when we had the protest, then we'd find most of them would be injuries. If you had the fire, then it would be most of them would be the fire. So it depends. It's really like you can. But mostly I would say it's the injuries or the trauma cases, as we call them.
Yeah. And tell us why the facility is so attractive to the community.
I wouldn't say why it's attractive to the community. but I'll put it, it's more about the values of MSF. For one, we provide, we are neutral. We don't choose who we treat. Anybody who comes in, as long as there is a need, there's a medical need, then we'll treat that need. Two, our services are free. We don't charge. It will depend. That's why, like, even in the trauma center, we have the triage that would assess the needs of this patient, whether they need to be seen here. Because at times, you remember the 90 patients I was telling you about, some of them are seen at the triage, and they are discharged once they are sorted there, and they don't need. So maybe because we are offering free services and we are bound by medical ethics as part of our principles of MSF, I can only speculate. Maybe these are the reasons why people come to us.
Okay. Do you allow any patient to walk in? You have a criteria of the patients that you attend to?
So for the patients that we see, like I said, primarily it's supposed to be a response to urban violence. We treat injuries, but again, we have exceptions because, like I said, we usually do the triage for the injuries and treat accordingly. But we have an exception for people living and working in the street, or the street families. So for these ones, it's irrespective. It doesn't have to be trauma related. So even if they have other medical needs, we usually attend to them. And then based on our location, we are next to Isli and Kiamaiko. So there are a lot of immigrants, and most of them are undocumented. So for this cohort, we also attend to them irrespective of their medical needs.
Challenges that you guys are facing?
I would say, okay, we at times we've had incidents and challenges. I would call them like that, and sometimes they are beyond us. One of the biggest challenge we have, and it's more about the systems, is the turnaround time of the ambulance. We have 3 medicalized ambulances and 1 for SGPV. So the calls sometimes take longer because of the processes. Right now, one of I would call it more of an emerging issue than a challenge, because we have the new shift and SHA. Because primarily all our referrals are sent to public facilities, Mama Lucy being the first one, and then at times Kenyatta and Magadi. So because of the processes, like the need for registration and all this, you realize at times the ambulance takes quite, like the longest we've had, like 3 hours for an ambulance, and then it means people who might be requiring ambulance services may have to wait or get alternative because the ambulance is held at the facility. That is one. Number 2, I would say it's more of incidences. During the protest, one of our ambulance was stormed by the protesters, and there was also another incident again of storming of the ambulances. And for me, I feel being a medical organization with our values of neutrality, impartiality, and we are responding to medical needs, the community really need to respect and give us this space to work, because we are offering life-saving services, and we usually don't take any side. We are there to respond to the medical needs. So those 2 are some of the challenges I would say that we are facing.
What of accessing patients in places like Mathare? Is it a challenge for you people?
Not really, because we accepted in the community, and the community knows what we do.
I'm asking in terms of infrastructure. Maybe kuna mahali, like when it was flooding, were there places you couldn't go because there are no proper maybe walkways?
Okay. Accessibility has improved over time. because I came in around that time that there was flooding, and it's not a coincidence that you see our ambulances are 4x4, and we are in Nairobi, so it's about access, and we also have like the big van, as one of our ambulances is the highest, and there was a time we had an issue with access. I think it was in Kosovo, Madare, and through the project coordinator's office and the community leadership, we were able to have the access made better. So they engaged the community. There were some structures, leveling of the road, and it was done. It was done by MSF, but at least there was that engagement, and it was easy.
So if the community has accepted you, it's proper for me to assume that there are no security issues for your staff?
None so far. Apart from the medical, apart from the facility, like the emergency services department, we also have other support department like the logistics, the project coordinator, and also the community team, who help us with sensitization with the community engagement. We also have feedback sessions. At times I'm involved, at times it's just the community team. So if there's any feedback from the community and engagement, or even there's feedback from the community, maybe on areas that we need to improve, we usually get this feedback. And in our meetings we sit down and decide on how best to move forward.
Okay, let's go to the last one. Emerging issues, street families.
So for the emerging issues, I would mention two. That one is the recent protests, because they are more unpredictable. So historically we've been responding to protests, sometimes the election, the politically instigated violences. That is within Madare. We have this one, you can actually plan. Like, election time it's coming, and you can do your advanced trauma posts, get enough staff and all that. But with these ones, with the recent protests, it's really not easy it's unpredictable. Nonetheless, we've been responding, and whenever we get information that there's potential protests, even as recent as the other day when we had protest in Eastleigh about the femicide. Yeah, so when we get this information, we usually plan like a day prior. We increase the number of staff. We're just on standby in case of any eventuality. So that I would say it's one of the emerging issues, but we also adapt. The second one is for the people living and working in the street, that is the street families. We have started, it's more a social response. And by this I mean, these are people who have, it's about access to healthcare. So we are trying to increase their access to healthcare, specifically secondary healthcare. And one of the things that we are doing is registration. We are trying to facilitate the registration for SHIF and SHA, so that it makes it easier for them to access secondary care. And then whenever there are instances that, because these ones they cannot pay, as much as we have the waiver system in the government, there are some services that are not waivable, such as CT scan, maybe what you call internal fixation. So in these instances, when we get somebody from the street who can't afford these services, then MSF comes in and facilitates for them. And it's not this service. It's not also unique just to the street family, but also the other vulnerable group, which is the immigrants, and most of them are undocumented. Like I said before, MSF is a medical humanitarian organization, and we respond to the needs of the population, the medical needs, medical and humanitarian. So as long as we are in Mathare, we are always ready, and when called upon, we will respond. The case that we picked from the community, we arrived, we received a call in the morning from one of the community member, and we dispatched an ambulance. I was part of the ambulance team. So when we arrived at the scene, we picked the patient, loaded him into the ambulance, because already there was a crowd that was building up. So we put him in the ambulance, did an assessment, stabilized at the ambulance, and then after that we came back to Lavender House, because we felt that the patient needed further stabilization and observation. And once the patient came in, our team assessed him further and decided that he required further management. So they proposed that we refer him to, and like I said, our primary referral facility is Mama Lucy for further management. But the patient is stable, and he's better than we found him. For the patients that come to the clinic, we have two categories. There are those that already know about our services and they walk in, or some are even brought by Good Samaritans. But for the call centers, we get the calls from the community. We also have community health volunteers. Sometimes we get from the police, like the traffic police on the road, and they know about our services, so they would call. But in these categories, like there are those people, like you would find like the community health volunteers, they know about our services, and they will be contacted, and they contact us. What we call the frequent callers. So we have, I would say, the police, community health volunteers, and some are even individuals that have access to our numbers and know about our services.
Mimi naitwa Amina Hassan, nafanya kazi na MSF kama health promotion officer. I'm the link between the community and MSF. The community and MSF also. It's a two-way. So we do a lot of awareness in the community on the aspect of sexual violence. That is rape, defilement, sodomy in the community. So we emphasize on the aspect of medical intervention. Why is it important for someone to go for medical intervention? So for the community to understand that aspect, within 72 hours, the survivor is supposed to go for medical intervention so that at least they get prevention of HIV, STIs, and also pregnancy. The community is diverse. So I work in Mathare, Kamkunji, and some part of Makadara, Isili. Yes, Isili is actually, I also focus on the refugees community so that at least they understand the aspect of sexual violence. What is sexual violence? What are they supposed to do? Because for them, sometimes there's that aspect of fear. So they don't even know where to start. So I emphasize for them to come for medical intervention within 72 hours so that at least they get the help. Yes. Emergency program, actually we do a lot of awareness on the criteria so that at least for them to understand the criteria. Because for an ambulance to be sent to the community, we must have the criteria. So the criteria are like something like an accident, someone who's really bleeding, a mother in labor, someone who has been maybe severe burns, and children who has very severe fevers, someone who has diarrhea and then they have already there's dehydration. So such criteria is very important for them to understand. We create awareness for them to understand the criteria for the ambulance to be discharged so that at least when they are asked questions, they don't say that, why is the call center asking me a lot of questions? Yes. The common challenges people come here mostly are aspect of accidents, Maybe there's also violence, a lot of violence, people, violating each other. There's wound stab, something like that. Sometimes even, there are also aspect of GBV in the community, domestic violence, where people, violate each other. Sometimes even men are beaten, but sometimes they don't come. So we emphasize also for men to disclose within the community.
Mimi kwa jina naitwa Christopher Mwe. Mimi ni mhudumu wa afya. Ninakaa hapa Mathare. Mwaka mingi niliingia akiwa ni kijana 1975. Lakini wakati nilikuwa hapa nafanya kazi ndaseria. Lakini wakati ambao niliwacha nikajiunga na kanisa, nikachukua huduma ya afya ndani ya kanisa. Basi wakati unapochukua huduma ya afya ndio nikaanza kusuka katika kijijini. Nilipozuka kijijini ndio sasa akaanza hata blouse amesaidia sana. Kuna mama mmoja anaitwa sana daktari mwingine anaitwa Mangari ambao tulikuwa nafanya kazi naye. Wakati huo ulikuwa CHV ndio ugonjwa hiyo kimwe ilikuwa imeanza. Wakati huo watu walikuwa wanafanya wanahara na tabika na hakuwa anajua mahali wanaenda. Sasa wakati huo ndio sisi tukaingia huduma kama hiyo, kuenda kutoa health store katika hospitali ili tuweze kulemisha watu wakubali kumeza dawa wakati ambao umepatikana wewe ni mgonjwa na ukubali kufuata ushauri ya daktari. Hiyo ndio kutoka hapo ndio sasa tumeendelea hata upande wa serikali akakuja baadaye hapa kwangu hapa Mathare 3B ambao hapo niko sasa. Hapa naitwa Mlango Kubwa, naitwa Kiboro sublocation. Wakati hiyo mimi nikaenda nikauliza, mimi area yangu hakuna unit yote, mimi ningependa tuletie upate watu nifundishe kazi ili waweze kufanya kazi pamoja nao. Basi walikubali, wakapatiwa, kuambiwa akapewa watu kama nafasi ya watu 65 ilipopewa kazi naye tuliandikisha tukasomeshwa wiki 2 ambao wakaanza kazi. Lakini wengi wao walianza kutoka tena kwa maana hakukuwa na malipo. Nasema ni kazi ya bure au utafanya. Sasa mimi na habari kwa unity bado mimi niko kwa maana mimi ndio nilianza, mimi bado niko. Wakati kama hizi sasa serikali ameanza kujua umuhimu wale watu wa promoters CV kazi yao. Sasa ikapata kama mimi niko na watu kama watu 15, watu wengine walikuwa wamesaenda. Ndio sasa tunaendelea. Lakini kuingia katika NSF amesaidia sana kwa sababu wakati mwingine nilikuwa nafanyia hapa na kuna mali ya kupeleka. Wakati mwingine nilikuwa nafanya hata transport ilikuwa nalemea mimi kwa kupeleka watu hospitali. Wakati hilo nilipewa ile kitu nilikuwa napewa, hata mimi nimeshapewa vitu tu za kazi mingi, hata wheelbarrow ya kusukuma nimeshafanya kazi naye. Nimeshapewa kitanda ile bolsera ile nabeba naye wagonjwa. Pia hiyo umepewa ili tuweze kubeba naye wagonjwa.
Tuambie venye ulikuja kujua kuhusu MSF.
Sasa kuliko kujua MSF ndio nilikuwa nimemwambia wakati tunasaidia wagonjwa waache HIV. Hiyo mwaka mimi nilianza huko 85. Wakao bado tuko blue pale chini. 85 ndio tumefanya kazi kutoa Elstock, kiwa na Steven, kiwa na Beka, kulikuwa na wengi sana, mama wengi ambao sasa hayuko.
Na siku hizi mnarifaa cases kama gani kwa MSF?
Wakati kama hii tunavaa cases kama ile raping, mama gender based na ajali ambao na bibi na bwana wakiumishana, wakipigana kwa nyumba. Wale wakijana pia mengi ambao unapigwa wakingangana mambo ya malipo yao, ile pesa wamenyang'anyana. Pia yote tunachukua tunapeleka blouse.
Hospitali yenye karibu ya serikali hapa ni gani?
Hapo hospitali hapa karibu hakuna. Tulikuwa na Mathare hospitali ambao ni ngambo ile. Nyingine wa leo ziko huko Huruma. Hapa katikati yetu hakuna hospitali yote. Blouse ndio inatusaidia. Ile nyingine Sobko na Baraka. Na hiyo ni kwa area nyingine Kasarani. Yeah.
Na sasa watu wakitibiwa huko MSF wanasemaje?
Watu wakitibiwa wanafurahi. Watu najua kile vitu watu wa kusaidiwa na kuwa wengi. Zamani wakati nilikuwa nafanya watu nilikuwa napeleka hospitali Kenyatta, ilikuwa hata nalipiwa paka bili. Ilikuwa nafuatiliwa nalipiwa paka bili. Lakini watu ikiwa wengi sasa imekuwa sasa dona akasema hiyo imekuwa pesa natumika mingi, akapunguza ndio kapatiwa gari ambulance. Ya sasa kubeba wagonjwa kupeleka hospitali nyingine kama Nairobi 5 kama Mama Lucy, Mama Mbagathi, Kenyatta, hiyo ndio tulipatiwa hiyo.
So wiki kama moja unapigia MSF simu ngapi?
Mimi kama wiki moja naweza piga hata kama 10 hata 15, kwa sababu nilisema hapa kwangu ni kama NSF pia. Hata kama ni mtu ambao umevunjika pale hapo itapigiwa simu. Baba Mili, tunataka tusaidia na namba ya NSF. Nataka gari. Mtu yetu amegongwa na pikipiki au amegongwa na gari. Yeah.
Alafu hii mambo ya SHA na SHIF. Watu hiyo challenge ya registration na nini watu wanasumbuka sababu yake na MSF inasaidia.
Kwa upande wa sana NSF wakati ambao serikali ilibadilisha saa bado watu walikuwa bado hajajua njia yake mzuri, lakini wakati huu tunapoendelea litumwa kwetu kama CGB au kama nyumba 10 ilisema serikali ilisema elder wa kijiji pia kuingia kwa kutuma kuregister watu. Sasa tunaendelea, lakini bado ilikuwa vigumu kidogo kwa maana saa au kwa na pesa. Unajua mali unapelekwa pesa natumika, lakini ile pesa kutoka kwa NSF au bado ilikuwa transfer pesa yao kwa saa. Sasa ilikuwa ngumu. Kwa hivyo tunaomba kama wao watu utakuwa mzuri, kwa maana sasa hivi tumeregister watu mingi, kwa maana hata bili niko hapa mimi si kuhangaika sana, hakuna kitu lilalamika, kwa maana niliwacha kuregister saa na ikatumikie mimi mpaka mimi nikatoka hospitali.
Na watu wengi kwa kijiji, unaweza kuwa umeregister sababu ni HCHP, watu wengi wameregister.
Watu wengi wameregister, lakini bado watu iko naombaga sana. Wanauliza maswali mingi. Wanaona kama hata kama na register haitasaidia. Kwa hivyo bado natakana seminar itwe. Mimi na mara mingi sana najua kile nikiongea mimi kama Christopher iwezi kusikika kama tuko wengi watu 20 au watu 10, tukifundisha watu 20 atajua aende aongelesha watu wengi, hiyo itakuwa kazi itakuwa rahisi. Ndio naomba kama inaweza kupatiwa kama seminar sisi kama CGB iwache kupatiwa seminar itakuwa ni rahisi, kwa maana serikali haikubali, hana uwezo, hana nguvu kuita seminar mingi, inaonyesha dogo.
Sasa ya mwisho tuambie jinsi unaeleza watu kwa community kuhusu MSF. Unaeleza kwa baraza ama kila siku ama unafanya aje?
Kama vile mimi nimwambia mimi ni elder senior chairman ambao nimeshafanya mwaka 30 years. Wakati ambao niko kijiji watu wanaamini, nikimwambia watu vile wanaweza pata usaidizi wanaamini, na ndio nimemwambia hata kiwa iko hapa napigiwa simu. Hiyo ni kulingana na vile mimi nimeshapeana ujumbe, na wakati ambao niko katika baraza pia napeana ujumbe watu wajue kwamba vile naweza kusaidika. Kuna NSF ambao naweza kusaidia wakati ambao wakitukuita wanaweza kusaidia, lakini wamesaidia mingi. Unaona kama hiki kiwanja hapa Kambi Safi, unaona watu wale masafara wamelala ngapi? Ukienda sasa kwa masafara wagonjwa hata wengine ni abasa anapatia pesa aende Kenyatta aendi, na hiyo hata tayari hiyo unaona wakati unaohudumiwa natakana pia ujidumie, lakini wamesaidia sana. Mimi kwangu upande wa NSF kama vile juzi nilipata ripoti kwamba kuna ufanyikazi napunguzwa, nilikuwa nalia sana kwa sababu huduma haitafikie watu, kwa sababu hii watu kama wamepunguzwa ingesema watu waongezwe ingekuwa kazi rahisi. Ndio sasa huduma ikuwe nini ukue ni wetu, lakini kupunguzwa sasa itafanya watu hata hawataelewa mali naenda, kwa maana kuna NGO imetoa kama head up au iko bado chini, nikipeleka pale mtu bado hao wanapiga simu kwenye mimi bado ni mhuduma hata NH hapo hapa head up mali yote, lakini bado nikipeleka mtu wanaambia patie namba. Hakuna namba yenu sasa nimepeana. Wanapiga mara moja, unakuja kuangalia, kwa maana hata wakitoka hospitali najua anakuwa kazi rahisi, kuna mambo mingi imeshafanywa. Kazi yenu sasa ni kujua, ni kusaidia bila ambao mgonjwa anaweza pata tibabu. Mimi jumbe yangu kwa community, mimi nimeshukuru sana kwa kutembelea mimi, ingawa umetembelea akiwa mimi iko chini. Hata wakati kama ingekuwa nafasi, kama ingekuwa kama bila baba mimi, tungetembea pamoja, hiyo jumbe ingeendelea sana. Lakini nitaambia watu wa community kwamba wajaribu waamini, kwa maana watu wengi nasema kabla hujafikiwa hutaamini, lakini waamini kwamba MSF nasaidia sana sana. Hata juzi mimi nilikuwa nataka kuja kwa basi hapo, kwa na shida kidogo, kwa sababu mara mingi sasa nabeba watu mkuteni na ile na pikipiki. Nataka gari, kama gari ni kidogo ongeziwe gari, au utengwe gari fulani ambao inaweza kuchukua emergency haraka, kuliko mgonjwa akuje pale na utafuta watu wa kubeba, na hiyo watu pia wengine ni walevi. Hao ni walevi, hawezi beba mtu, akishika mtu anaanguka chini, naambia wewe beba hiyo mtu lete kwa hiyo. Naomba hiyo jaribu sana, tuwekeni mabadiliko tuone. Mimi napenda sana tuendelee vile livyo, na kazi kuendelee mzuri, na nimeshukuru sana wale kinaamini, wale ambao tunafanya kazi naye mpaka mahali imefika. Hiyo huduma hii amesaidia watu wengi. Wale watu ambao tulianza ndio huduma, wengine wameandikwa, mimi ndio nilikataa kuandikwa, kwa maana nilisema nimesharataya kwa kazi, sasa siwezi kuandikwa tena, wacha mimi nifanye kazi kwa kijiji, na ndio bado niko mpaka sasa.
Kwa majina naitwa Peter Diboy Wanjiro, na fanyanga na shirika Zero Street Child Foundation, na wanga tunafanya partnership na MSF juu ya our street family. Tunadili na street family ambapo wakigonjeka kwa street tunawaleta hospitali. MSF wakiwa na hizo referral wanafanya, wana come back to us, so tumekuwa tukifanya kazi nao na tunafanya kazi fiti kwa society. Kazi yenyewe tumefanya na MSF ni kazi fiti, because hakunanga usituko nazo zinafikirianga the street family kwa society. So kama ni referral, kama ni msetu umetoa kwa street pale, ama msetu amegonjekea kwa street pale, tukipiga simu MSF wanatupatia ambulance, wanakuja pale wanamchukua. Akifika kwa hospitali ni kesi ambao haitasortiwa hapo kwa MSF, watampatia maybe referral ya Mama Lucy ama Kenyatta ama wengine Bagati, na wakifika pale wanahudumiwa vizuri, na tunashukuru Mungu kwa yote, because imekuwa na impact na tumeona changes, because wase pia wamekubali kuitika kwa kujileta pia hosi wenyewe. Sasa wale wana ID ndio tumekuwa na issue nao, kwa tunapata sisi shirika letu la Zero Street tunafanyanga kuregister the street family vitambulisho. So unapata kuna ule msika amegonjeka hana ID, na maybe hata hajafikisha miaka ya ID. So wanga tunaenda hospitali, kwa tumejaribu pia kufanya partnership na hizi hospitali, tunawazungumzia sisi wenyewe. So unapata nitaregister mtu, na kama nitaregister mtu na ID yangu, itajike ni namba ya simu ni yangu tu ndapeana, ama ya social worker wetu. So unapatanga tunajaribu kufanya the partnership pamoja hivyo.
Na kwa sasa mmesaidia wangapi ku register kwa SHA?
SHA tuko na a number, hiyo ni tuangalia kwa record, but tuna big number. The big challenge tutakuwa nayo, MSF watafanya referral na msi apeleko, like amepelekwa Mama Lucy ama amepelekwa Kenyatta, hana ID. Unapata mpaka wanataka kumhudumia, because wanasema tuhudumia non. So imekuwa ni a big challenge, na ni kitu ya pia unapata tuwakosa pia na madaktari pale, because for us tumejaribu ku rescue the life, but ikifika pale koziana ID hata hudumiwa.
So solution according to you?
Solution is the government na hospitali wajaribu ku cooperate together, na pia ku understand si kila mtu amefikisha miaka ya ID. Kila mtu anagonjeka kwa street na maybe hajafikisha miaka ya ID. Second thing, kupata ID kwa street haijakuwa easy. Wanapatanga ID easy wakati wa campaign. Hii time nyingine inakuwa ni ngumu. Hii ID unalipia. Safari atatoa pido ya kulipia ID, ni ya kukula mani ya ID atapata. So sasa imekuwa ni challenge, na ni big challenge, inatumiza actually.